In this lecture, I'll be covering stroke management. Here are the learning objectives along with recommended reading, and I would highly recommend you go back and review prior lectures on stroke if something doesn't make any sense. So let's review just a few basics. First, it's important to understand that the brain is very selfish. It requires 20% of the total blood pumped by the heart, and it has no backup fuel or oxygen, so it requires a constant supply. 80% of strokes are ischemic, whereas 20% are hemorrhagic. Also, if I were to ask you what is a TIA versus a stroke, could you answer that right now? Remember, a TIA is a temporary neurodeficit without infarct on neuroimaging, whereas a stroke is a neurodeficit with infarct presenting on neuroimaging. To understand stroke, you have to understand the blood supply, though. Very important to understand because this helps you determine what workup you're going to do on a patient who presents with a stroke. It's important to understand that there are two circulations to the actual brain. The first is the anterior circulation. You'll see the subclavian branches off into the carotids, which divides off into the external and internal carotids. The internal carotids feed into the circle of Willis, which feeds the anterior, middle, and posterior cerebral arteries. The posterior circulation, you'll see here the vertebral artery comes off later on and goes up the spinal column and turns into the basilar artery. This also feeds into the circle of Willis and is a backup to the anterior circulation, but it also supplies the midbrain and the cerebellum with blood. Now I'll discuss how to classify strokes. Why does it matter what type of stroke the patient actually had? Well, because they have different causes, outcomes, and treatments. So strokes are divided into ischemic, remember those are 80% of strokes, and hemorrhagic, which are only 20%. Ischemic strokes are further broken down into thrombotic, embolic, and hypoperfusion strokes. Thrombotic, just like an MI in the heart, a plaque ruptures causing a thrombus that occludes the blood flow to that area of the brain. This can further be divided based on whether it occurs in a large vessel, such as the carotids, vertebral, or basilar, or a small vessel, such as the penetrating arteries of the cerebral arteries. Small vessel strokes are primarily lacunar subtype. Lacunar strokes are small subcortical infarcts that typically are silent and found on imaging when you are evaluating for something else. Typically, they're due to small vessel disease, usually the penetrating arteries from the middle cerebral or the basilar arteries. They typically only cause an isolated motor or sensory syndrome and rarely affect cognition or mental status. The most common causes are hypertension and diabetes, which leads to small vessel occlusions with resultant necrosis that gets reabsorbed over time. Embolic strokes occur when a clot, plaque, or fat such as long bone fractures or etc. break off and travel distally. They are typically from the heart or proximal arteries such as the aorta, subclavian, carotids, or vertebrals. Hypoperfusion is when a patient is hypotensive. Think of a patient with sepsis or a septic shock or cardiogenic shock. The patient will have diffuse ischemia of the brain, which is worse in areas where the patient already has ischemic disease. And then there's hemorrhagic strokes. These are further defined as intracranial hemorrhage, which is broken blood vessel inside the brain, or a subarachnoid hemorrhage, which is a broken blood vessel on the surface of the brain, or a subdural hematoma, which is usually venous and due to trauma to the head. So stroke workup begins first by taking a careful history. This will tell you actually what type of stroke it was. Was it ischemic or was it hemorrhagic? You find this out basically off of their history. This also helps you determine what the onset of symptom time was. This is imperative for determining if the patient is a TPA candidate. For instance, like embolic strokes, these occur suddenly, are maximal at onset, and can resolve rapidly. Whereas thrombotic strokes, symptoms can be, waxing and waning, or they can progress in like a stepwise fashion. Intracranial hemorrhage, these progress gradually from minutes to hours, whereas subarachnoid hemorrhages develop instantly. The physical exam, however, it tells you more of where the stroke is located at. So you do the physical exam, you determine where their deficit is at or what neurologic deficit they have, and this is where you guess to yourself, okay, I think that they've had a stroke in their left MCA based on these symptoms. So then after that, that's when you get diagnostic testing. And the diagnostic testing is basically to confirm what your hypothesis is. So the symptoms of stroke are very broad. This is a very broad topic. Honestly, I like to break it down into 4 categories. Focal versus non-focal. That's your first category. So you just want to know whether the symptoms are focal or diffuse. This helps distinguish a stroke from other causes. Focal symptoms are more likely an ischemic stroke, whereas non-focal symptoms are likely a hemorrhagic stroke. Other causes, such as generalized weakness or deconditioning, can also cause non-focal symptoms. Timing. You really have to know the last time the patient was normal. For instance, a patient wakes up at 6 a.m. with a deficit. They went to bed at 10 p.m., so the onset time is considered 10 p.m. This is important because it determines if they are a TPA candidate and how quickly you need to work them up. Quality. Are the symptoms worsening, which indicates either progressive intracranial bleeding or ischemia, and essentially rules out a TIA? Are the symptoms persistent, which also rules out TIA, which means that a stroke is likely to be present on neuroimaging? Are the symptoms resolving, which likely indicates an ischemic stroke or a TIA? Or are the symptoms waxing and waning, like I had said? I like to think of a patient with hypertension. So think of a blood vessel that's kind of clamped down or, hypoperfusing. This would necessitate aggressive fluids and pressors. Obviously not pressors if the patient has hypertension, but if they're hypotensive, it would. Next would be associated symptoms. So like a patient with headache, this is important because they need a spinal tap to rule out subarachnoid hemorrhage, especially if the initial head CT is negative. Do they have altered mental status or altered level of consciousness? This is likely due to hemorrhagic stroke or an encephalopathy due to infection, could be toxins or drugs. And then do they have any nausea or vomiting or hypoxia, something that might make you think that they've aspirated? So a little more about the stroke workup. First is neuroimaging. So number one, when the patient's in the emergency department, they're always going to get a stat head CT. This is done without contrast, and it's mainly just to rule out a hemorrhagic stroke. If the patient does have a hemorrhagic stroke present, then, it's automatic neurosurgery consult. If you do happen to see an ischemic stroke, this is very rare, but it usually indicates a poorer prognosis. So once that CAT scan is done, a lot of times it's important, if you're suspicious of an ischemic stroke, to get a CTA of the head and neck at the same time. This can often be done within minutes, so you're really not going to delay the patient getting TPA. This is done to see if the patient has a clot that is amicable to thrombectomy or, further TPA inside of the blood vessel. So then once those initial CAT scans are done, and those are done stat, so let's say you've got a patient with ischemic stroke that you're admitting. Well, there's really no point in getting any emergent imaging, especially if they're outside of the window for TPA. So really their workup is just going to be figuring out where the stroke is, the size, just to help determine antiplatelet use and to prevent them from having a future stroke that could be worse than the one they're having. So with this said, you typically get an MRI without contrast of the brain. You can add contrast, but this does take a chance on hitting the kidneys. And I mean, with contrast, basically all you're doing is helping to rule out infection. It can help rule out MS. It can help further evaluate tumors. But most of the time when a patient presents with ischemic symptoms, we're really not worried about those. We just want to see exactly what brain tissue has been infarcted. And a lot of times it's good to wait a little while anyway, because you'll be able to better see the ischemic area on the MRI. So once MRI is done, you'll want to get the MRI, but also you need to consider echocardiogram. So if you're concerned at all about an ischemic or a embolic stroke, you need to start out with a transthoracic echocardiogram. This is done in most stroke workups just to evaluate for a clot somewhere inside of the heart. The only problem with these echocardiograms is that sometimes they miss a clot in the left atrial appendage. Sometimes they can miss mitral valve clot. It's rare, but it can happen. Now, if you do have suspicious on that echocardiogram, but you can't fully characterize it, then you need to see if the patient's a candidate for a transesophageal echo to further evaluate it just for, diagnostic purposes. Also, you should consider, I should have mentioned it above under neuroimaging, carotid Dopplers. So you need to evaluate whether or not, so you're basically evaluating from the heart up. So you've got to evaluate the blood vessels in the neck. This can either be done with a CTA of the head and neck, okay, or you can do it with a carotid Doppler. Now, a carotid Doppler only images the anterior circulation. So if the patient has anterior symptoms, which I'll get to later, then you know that really all you need to do is evaluate the carotids, and that will be more than fine. The problem is carotid Dopplers can sometimes over-predict disease, and then you refer them to a surgeon and they end up getting a CAT scan anyway, and then it says, no, their disease really isn't all that bad and we can wait a while. So the other option is to get a CTA of the neck, the head and neck. You typically do them both at the same time, and this will actually investigate the anterior and posterior circulation at the same time. The problem with it, though, is that you're giving contrast, so you can hurt their kidneys, stuff like that. So telemetry is really important to put all ischemic stroke patients on. You want to watch to see if they've got any underlying AFib to where they might need to be added on an anticoagulant. Also, neuro checks is really important. You've got to document these. This is part of any stroke protocol. Typically done every 4 hours. It's done much more often if a patient's actually getting TPA. Antiplatelets, very important in ischemic stroke. Usually you give aspirin within 48 hours to reduce the risk of recurrence. And I'll talk a little bit more about antiplatelets on the slide or two. Also statins. Even if their cholesterol is normal, which typically you're going to check a fasting lipid profile on these patients, you still need to consider adding a statin just because it helps stabilize plaques. I know a lot of hospitals now, it's actually a quality measure where, they ask on discharge, did you prescribe them an antiplatelet and a statin at discharge? Other orders you need to consider is making the patient NPO at least until they've had a bedside swallow eval or they've been seen by a speech therapist to make sure that they're not going to aspirate into their lungs. Sometimes you can affect the swallowing reflex from a stroke, and the last thing you want is to add aspiration pneumonia on top of their stroke. IV fluids, especially if they're NPO, you'll want to give IV fluids, but you also want to be very cautious with this also. Normal saline is typically best, and you want to avoid fluids containing any glucose, which may exacerbate their hyperglycemia. Remember, hyperglycemia can worsen their brain injury. This is typically due to increased tissue acidosis from the anaerobic metabolism. They also get free radical generation, and they get increased blood-brain barrier permeability from the hyperglycemia. So you don't really want to give them fluids with glucose in it. As mentioned, you want to get a fasting lipid profile just to determine if they have underlying hyperlipidemia, but it really shouldn't stop you from starting them on a statin. You just start them on high-intensity statin anyway. Do you need a neurology consult? This is something to consider based on what your suspicion is, and if you need further help, or if you're really worried something else is going on with the patient. NIHSS scores, this is something that is automatically done. It's pretty much a part of any order set for stroke in the country. It stands for National Institute of Health Stroke Scale. It measures neuroimpairment using, it's like a 15-item scale. It's basically become the standard stroke impairment scale, and it's used to predict long-term outcome after acute ischemic stroke. The limitation, though, is it really doesn't capture all stroke-related impairments, particular vertebral basilar circulation strokes. Also with strokes, you want to get therapy evals. You want to have them seen by physical and occupational therapy along with speech therapy, just to make sure to see exactly what their deficits are to help arrange outpatient needs. Perhaps they need a nurse at home, or home health care, or they need to go to rehab, something like that. And therapists are, great at assessing that. And then you need to assess for VTE prophylaxis. It's important to not ever forget this, even in an acute stroke. You only hold this if the patient's getting TPA or has another major contraindication. So with anterior cerebral artery strokes, you can see from the picture that these primarily affect the frontal region along with some of the pre and post-central gyrus. That's the pre is, your primary motor cortex, whereas the post-central gyrus is your primary somatosensory cortex. And you can see here from the homunculus that you'll typically, it will affect your leg more than your arm. And also with frontal lobe infarcts, you'll usually see more cognitive and personality changes. Now on to MCA ischemic strokes. So from this picture, you can see that the MCA primarily feeds the temporal and parietal lobes and much more of the pre and post-central gyrus. That's, remember, your primary motor cortex and your somatosensory cortex. Therefore, you typically see much more involvement of the arm and leg of the contralateral side. The MCA also feeds the speech center of the temporal lobe. Just remember, the left hemisphere is considered the dominant speech hemisphere in about 95% of patients. So a left MCA stroke will typically cause much more speech issues than a right MCA stroke. Broca's, which is in the left frontal lobe, typically causes more expressive aphasia, whereas Wernicke's, that's the boundary of the temporal and parietal lobes there, that causes more of a fluent or sensory aphasia, so they can't comprehend like written and spoken language. They have neologisms where, they just invent words on their own. And then there's posterior cerebral artery strokes. These primarily affect the occipital lobe, which is primarily responsible for vision and sensation. Typically, you'll see visual field defects. You'll also have color anomia, where the patient can distinguish between colors, but they can't identify them by name or name the color of an object. They'll also have paresthesias without any motor findings. So just a note about single hemispheric strokes. They never affect paraspinal or pharyngeal muscles, or muscles of claudication, or the forehead. If these are affected, you should think, does the patient have bilateral hemispheric strokes, or do they have a brainstem stroke, or something else such as Bell's palsy? So speaking of that, do you remember how to differentiate a stroke from Bell's palsy? I'll just do a rehash of that. So you remember that a lesion of the facial nerve will occur before it reaches the brain, where the wires actually get crossed. Therefore, Bell's palsy affects the entire side of the face. Whereas in a stroke, the lesion occurs after the paths have crossed in the midbrain. Therefore, you will get forehead sparing. Now, as mentioned earlier, posterior strokes are important to differentiate because they require a different workup. Remember the blood supply. The vertebral arteries combine to form the basilar artery, which feeds into the arteries to the cerebellum, pontine, and then to the circle of Willis. The cerebellum oversees coordination and vision, so if a patient has vertigo or double vision, you should automatically think of a cerebellar stroke. Vertigo plus nystagmus plus nausea plus ataxia, these are characteristic of a cerebellar stroke. You will also often see cross-sensory findings, such as left face with right body hemiparesis or vice versa. And you can also see Horner syndrome. Do you remember what that is? So Horner syndrome is the combination of ptosis, anhidrosis, and meiosis. This patient has left-sided Horner syndrome. You can see the left eyelid drooping, the skin is drier with more visible wrinkles from decreased sweating, and the left pupil is constricted. The causes of this are basically anything that can damage the sympathetic trunk, such as strokes, tumors, or multiple sclerosis. So cryptogenic ischemic strokes, these are basically strokes of uncertain origin. You have no idea what actually caused it. This is typical of young people, so, always be concerned of these, but really they're a diagnosis of exclusion. You've got to rule out everything else. But it's typically seen in young patients with no risk factors. If you do find this is when you usually refer them outpatient and they get an autoimmune and a hypercoagulable workup. However, these patients may also have undiagnosed AFib and you just don't know it or you didn't see it on telemetry when they were in the hospital. So always, these patients you discharge on a 30-day Holter monitor and have them follow closely with their primary care or a cardiologist to interpret it. Now I'll touch briefly about hemorrhagic strokes. So first, subarachnoid hemorrhage, which is a broken blood vessel on the surface of the brain. So physical exam for these patients, you're going to have altered mental status, you're going to have nuchal rigidity, which is inability to flex the neck forward, and you'll have pupillary dilation. This is typically due to compression of the third cranial nerve or the oculomotor nerve. Now, intracranial hemorrhage. These present similarly to ischemic stroke, but with a headache and impaired consciousness as distinguishing characteristics. Hypertension also is the most likely cause, therefore the mainstay of treatment is hypertension control. So let's review a couple cases. So you've got a 60-year-old female who presents to the ED with headache, right leg greater than arm weakness, and expressive aphasia. What type of stroke do you think she had? Well, more than likely this patient had an ischemic stroke. Where would it be at? Well, more than likely, given her symptoms, I would guess she had a left MCA stroke that's ischemic. So now let's say you have a 70-year-old African-American male who presents to the ED with dizziness, double vision, left facial weakness, and right arm greater than leg weakness. What type of stroke do you think this patient had? So based on these symptoms, and you can pause this if you need to, but I would say the patient likely had an ischemic stroke involving the posterior circulation. Where at? So patient has cerebellar symptoms with crossed facial and arm greater than leg weakness. This is more consistent with a vertebrobasilar artery ischemia. So then what workup would you do for this patient? So initially you would get a head CT, right? And that would usually be negative. but you really need to determine the time of onset to determine if he's a TPA candidate. So what further imaging would you get? Well, after his initial head CT, which is likely negative, like I mentioned, you'd want to get more than likely a CTA of the head and neck with IV contrast to evaluate for proximal clot to see if thrombectomy is possible. Remember, this is a posterior circulation infarct, so carotid Dopplers really aren't going to help you. After this, you would also want to get an MRI of the head without contrast to determine the extent of the ischemia. You'd also want to get an echocardiogram to determine if a thrombus was present in the heart and to evaluate the valves and ejection fraction. And then other workup, as I had mentioned, you would want to get fasting lipid profile. You'd want to get therapy evals, including PTOT and speech therapy. Obviously, you'd get NIHSS scores. You'd keep him in PO until after a swallow screen. You'd start gentle IV fluids with normal saline. You'd treat any hyperglycemia he had. Then you'd start antiplatelets on him along with high-intensity statin. Now I'll discuss just a little bit more on stroke treatment. Okay, so TPA, also called alteplase. This is given if the onset of symptoms is less than 4.5 hours. It's based on criteria and usually administered by a neurologist. It carries a 6% risk of hemorrhagic conversion and overall mortality of around 50%. So basically it's a flip of the coin. But when you're talking about brain tissue, I mean, I would take that flip if I was going to be vegetative the rest of my life. Blood pressure management is really key. So you need to keep their blood pressure less than 180/110 if you're giving a patient TPA, or actually before you give them TPA. This is because the increased risk of hemorrhagic conversion with hypertensive emergency. So remember, for most ischemic strokes, you actually want their blood pressure to be high to increase perfusion of that area. But if you're considering TPA, you actually need to have it, under those parameters. It's usually treated with IV labetalol or nicardipine, and you don't ever give nitrates such as sublingual nitro or nitroprusside drip because those will increase the intracranial pressure. Also, I just wanted to discuss thrombectomy. This is usually done if the onset of symptoms is within 24 hours. Usually done in specialized centers, so I know like in Indianapolis it's done at Eskenazi and Methodist and I believe Riley, and I think St. V's does them also. Remember that you need a CTA or an MRI to determine if this is warranted, and that this imaging should not ever replace or delay giving TPA. So, I mean, you can do both. You can do TPA and thrombectomy, so yeah, always consider both. So the indication for antiplatelets has actually changed several times just since I've been with hospitalist medicine. But currently the recommendation is that if you have a high-risk TIA or a minor ischemic stroke, then you need to do dual antiplatelet therapy for 21 days, and then you change over to a single agent. So usually with this, you do like Plavix plus aspirin for 21 days, and then you change over to just aspirin alone. This decision is typically based on the stroke size, and this is where you'll get a neurologist to help you make that decision. So if they have a large ischemic stroke, then they usually require dual antiplatelet therapy for 90 days, then they change over to a single agent. So as mentioned, dual antiplatelet therapy is usually Plavix plus aspirin. Now they have done studies on Brilinta, and it's really, just about as effective. You can use Brilinta plus aspirin. The only problem with it is Brilinta is a lot more expensive than Plavix, so a lot of times it's not used in the clinical setting. So as far as anticoagulants go, timing is everything when initiating anticoagulants in patients found to have a cardioembolic stroke. Parenteral anticoagulants such as heparin or Lovenox used to be utilized all the time. However, they've been proven to cause more harm than good. So typically now with AFib and ischemic stroke, we use the 1-3-6-12-day rule. So if the patient has a TIA, you typically hold the anticoagulant for 1 day, whereas you hold it for 3 days for small non-disabling infarcts, 6 days for a moderate-sized stroke, and 12 days or more for large infarcts. And typically you get neurology to assist with this timing if you have concerns. So other keys to treatment, as already mentioned, statins should be started as soon as the patient is able to swallow. Another treatment that's kind of out there right now that's still being worked up is whether SSRIs are effective. Like I said, studies have been inconclusive, but some have shown that fluoxetine can actually enhance motor recovery. Honestly, the verdict's still out on this, though. And then VTE prophylaxis. Anytime you have an ischemic stroke, typically you want to use heparin over Lovenox. That's just in case they have hemorrhagic conversion. That way you can stop it and it will reverse itself right away, or you can give protamine, whereas Lovenox is much harder to reverse. So as far as blood pressure management goes, as mentioned, if the patient's getting TPA, you want their blood pressure less than 180 over 105. However, if they're not getting any TPA, then you only treat their blood pressure if it's greater than 220 over 120. This is because you don't want to decrease perfusion to that ischemic area. You typically start antihypertensives slowly over 48 hours, and your target systolic blood pressure is less than 130. The medications used for first line are labetalol and nicardipine, and these are given IV. And second line would be IV nitroprusside. However, remember that this one you usually use as a last resort because it can increase intracranial pressure in case the patient develops hemorrhagic conversion. Now, treatment specific to hemorrhagic stroke. Number one, you're going to consult neurosurgery or get them to a neurosurgery consult center so that they can evaluate the patient to see if they need to have any, obvious surgery done on it. You also want to place them in seizure precautions, so you'll put them in, pads on the sides of their bed. They won't be able to walk without the assistance of a nurse, stuff like that. They'll also get serial CAT scans. These are typically done at least once per day, and the neurosurgeon follows that. If the CAT scans are changing or if the hemorrhagic stroke is enlarging, that negates them going to surgery a little quicker. And then if they do have signs, symptoms of elevated intracranial pressure, you can consider giving them mannitol or hypertonic saline, but this is done in very small boluses, as I had discussed in the IV fluids lecture. And then hypertension management. This is done with the same meds as for ischemic stroke. You use nicardipine, labetalol. You can also use esmolol. And you don't want to give them anything that could increase their bleeding, obviously. So they would definitely not get any VTE prophylaxis, or you wouldn't, resume their home aspirin, Plavix, anything like that. So think about how this could be kind of dangerous. Say like a patient just had a drug-eluting stent placed in their heart. So, that's where things get very tricky, and you have to notify the cardiologist, and, it's like, what's going to kill them first, the stroke or, getting a new MI or blocking off their stent. So that's where you usually have to get specialists involved to help with your medical decision making. And here are the sources I used for this lecture.